And just for me to know, are you seeing the main view or the presenter, like presenter view or the notes view?
The presenter view,
Great. So you don't see any notes or anything?
correct.
Okay, perfect.
So we have all our fellows on board, Sebastian. So whenever you'd like to start, we're okay.
Perfect. I'll go ahead and get started here. Thank you so much for the opportunity to present today at the Sleep Medicine Noon Conference. For those of you that don't know me, my name is Sebastian Jara. I am an acting clinical instructor in the Department of Otolaryngology and Head and Neck Surgery at UW, predominantly based at UW Northwest. But I also did my residency in otolaryngology here at UW. I graduated in 2021, and then I recently finished a fellowship in sleep medicine and sleep surgery at the University of Pennsylvania. I finished that in June of this year, and I've come back in this kind of temporary role here at UW Northwest. And today I will be presenting on upper airway stimulation for obstructive sleep apnea. Importantly, I have no disclosures, in particular, no consultant roles or fees with Inspire or any other company involved with upper airway stimulation. My learning objectives for this talk will be to review the mechanism of upper airway stimulation, and particularly to discuss the role of the genioglossus muscle in maintaining upper airway patency, to discuss clinical implementation and indications of upper airway stimulation, and to present some of the outcomes pertaining to upper airway stimulation from the information that's been gathered to date. And in starting off, I'll give a very brief overview of obstructive sleep apnea, as I know that most of the crowd is quite familiar with this disease process. But for those that may be less familiar, it's a condition defined by recurrent choking episodes during sleep resulting from upper airway collapse. It's highly prevalent, present in an estimated 15 to 30% of adult males, 5 to 15% of adult females, and has some pretty important overall consequences, has some really significant long-term health outcomes, neurocognitive impairment, motor vehicle accidents, cardiovascular disease, stroke, and even increases the risk of death in patients that are not adequately treated. It also causes a pretty significant day-to-day symptomatic burden associated with significant sleepiness, deficits in function, as well as deficits in quality of life. As many of you are familiar with, the first-line treatment for sleep apnea is continuous positive airway pressure, or CPAP. It's the first line because it has a substantial body of evidence documenting efficacy and overall low morbidity. And while it is highly efficacious in that in patients that are able to use it well, it works quite well in addressing sleep apnea, reducing the burden of disease from sleep apnea, as well as improving long-term health outcomes related to sleep apnea. The effectiveness is moderate, and the primary reason for that is that adherence can be quite challenging for patients. The adherence rates have been reported at different levels, but some literature estimates that roughly 40 to 50% of patients are well adherent with therapy, which limits its effectiveness. And because of this, the duration of benefit for the long term isn't quite clear, as maintaining adherence can be quite challenging for patients. There are other treatment options available as well, including behavioral modifications such as weight loss and positional therapy, oral appliance therapy, and upper airway reconstructive surgery. And while these options have a good deal of effectiveness in properly selected patients, the treatment effect is often incomplete with these treatments. And there really hasn't been a good treatment that's one size fit all. Patient selection has remained critically important. And when you're evaluating for something like surgery for sleep apnea, the potential benefits in treating the condition are somewhat outweighed by the risk and morbidity of surgery, especially since the long-term outcomes for some of these procedures are not as well documented and elucidated. And that really brings a motivation for new treatment options to address obstructive sleep apnea. In particular, there's a need for new therapeutic options that can adequately treat patients with a high degree of efficacy and effectiveness, a need to address multi-level pharyngeal obstruction. Several of the kind of treatments, particularly upper airway reconstructive surgery, are more geared at particular levels, and there are fewer treatments that really address multi-level collapse. And there's also a need for more physiologic-based treatments in addition to the anatomic treatment. So with regards to upper airway reconstructive surgery, many of the treatments are anatomically oriented and less physiologically oriented. And the reason for that is, sleep apnea is a pretty complex and multifactorial disease process. While anatomic factors do play an important factor, such as skeletal structure, pharyngeal anatomy, there's a number of physiologic factors that come into play here, including kind of central respiratory output, so the neuromuscular control of breathing, arousal threshold, loop gain, and maintenance of pharyngeal tone and collapsibility, just to name a few of these factors. And one of the muscles that's really key to one of these factors, pharyngeal tone and collapsibility, is the role of the genioglossus muscle. So for a quick review, the genioglossus muscle is a fan-shaped muscle of the tongue. It's paired. It comprises the majority of the bulk of the mass of the tongue, and it's innervated by cranial nerve 12, the hypoglossal nerve. Its main function is to protrude the tongue, and each side will protrude and deviate the tongue contralaterally. So when they work in a paired fashion, this will result in anterior tongue protrusion. And it turns out that the genioglossus has a really central role in maintaining pharyngeal dilation and, in turn, maintaining upper airway stability. Some of the forces that are counteracted by the genioglossus muscle, there's a couple when you breathe in, a couple forces that are needed to counteract. One is the negative intraluminal pressure that's generated via diaphragmatic excursion. So when you breathe in, there's a negative pressure that's exerted, and that's one of the forces that the genioglossus counteracts. The other is the positive extraluminal pressure. So the soft tissues of the neck and the chest that really, well, for the genioglossus, the neck, the positive extraluminal pressures that kind of weigh in to lead to potential that's kind of necessary to maintain in order to maintain pharyngeal stability. In the state of wakefulness, reflex activation of the genioglossus muscle has been shown to maintain pharyngeal patency. And studies in sleep apnea patients have shown that even during the awake state, there's an increase in genioglossus activity as noted on EMG. And what this suggests is that patients with sleep apnea need to maintain a greater degree of activity of their genioglossus muscle to maintain patency of their airway, even in the awake state at baseline. During the sleep state, the dilator muscles tend to relax and the activity tends to decline during sleep. Studies have shown that the genioglossus muscle activity tends to increase with deepening sleep states. That's why during N3 sleep, the airway is noted to be very patent during that state of sleep. And the obstruction of the airway leads to increased activity of the genioglossus muscle to counteract that obstruction to try to maintain airway patency. So if there's some degree of dysfunction, this can lead to a failure in an increase in activity, which in turn can lead to collapse of the upper airway and predispose to an apneic event. There are several factors that can contribute to this impairment. A few listed here: aging, muscle atrophy, neurodegeneration, and even hypoxia and inflammation have been thought to contribute to impairment of the genioglossus. And because of the physiologic finding that some degree of impairment and dysfunction of the genioglossus can lead to airway collapse and apneic episodes, this really provides the biologic basis for augmenting the neuromuscular activity of the genioglossus muscle as a means of attempting to treat obstructive sleep apnea. And so, because of these findings, this kind of led to this area of looking at electrical stimulation of the upper airway as a means of addressing sleep apnea and better understanding sleep apnea pathophysiology. And some of the first studies that looked at this were actually some animal studies. So in 1989, the group by Mickey et al. Isolated the upper airways of dogs by performing tracheotomies on dogs and looking at the relationship between the frequency of the stimulation of the genioglossus muscle and upper airway resistance. And, what they were able to show was that as you increase the stimulation frequency of the genioglossus muscle, they were able to demonstrate kind of graded decreases in upper airway resistance when kind of measuring the upper airway as its own circuit after performing the tracheotomy on these dogs. Then in 1992, the group by Schwartz et al. Performed bilateral hypoglossal nerve stimulator implants on cats, and they were able to demonstrate that increasing stimulation frequency was associated with a direct increase in maximal inspiratory airflow, VI max, as well as a decrease in the critical closing pressure of the upper airway, or the P crit as they denote it. So as you increase the stimulation frequency of the hypoglossal nerves, they observed increased maximal inspiratory airflow and decreased airway collapsibility. This was again demonstrated by Olivan et al. Through selective cranial nerve 12 stimulation. So this is unilateral and selective, and kind of performing a similar study in dogs. They looked at pressure flow relationships of the upper airway, and were able to see that stimulation of the hypoglossal nerve resulted in an increase in maximal inspiratory airflow and decrease in airway collapsibility compared to controls. Some more important animal studies. So a group by Isley et al. Conducted studies on isolated feline upper airways and basically placed electrodes along the hypoglossal nerve as well as the ansa cervicalis. By kind of performing selective stimulation, they were able to conclude from this that a major decrease in upper airway collapsibility via hypoglossal nerve stimulation was dependent upon activation of the genioglossus, and that placement of the electrode on the proximal segment of the hypoglossal nerve resulted in the largest improvement in maximum inspiratory airflow. Further work into kind of selective stimulation was performed by a group by Bashara et al. And in a study on spontaneously breathing dogs, they performed selective stimulation of the genioglossus as well as other pharyngeal muscles, and noted that selective stimulation of the genioglossus led to the largest decrease in upper airway resistance. Finally, as far as kind of the animal models are concerned, a study by Goding et al. was pretty critical in terms of the development of therapeutic options. So they reported data on chronic stimulation of the hypoglossal nerve in dogs using bilateral cuff electrodes placed around the hypoglossal nerve. And they performed stimulation starting at 4 weeks after implantation of this device, and for a period of up to 8 weeks at a ratio of 8 hours a day, 7 days a week. So really stimulating that nerve a lot. And while they were able to demonstrate kind of similar improvements in peak airway flow during the stimulation, importantly, it was noted that this didn't cause any damage to the hypoglossal nerve due to chronic stimulation. So this was some compelling evidence that long-term hypoglossal nerve stimulation in humans might be safe and might not result in nerve damage. And so as a result of these studies, some of the first human studies were performed. And to be honest, at the beginning, many of them had pretty mixed results. There were attempts made at performing both transcutaneous stimulation of the upper airway as well as transoral stimulation. And these bore mixed results, partially because patients had some difficulty tolerating the electrical stimulation. And while some findings were noted, reproducibility of these findings was quite challenging. The first kind of successful study demonstrating this was by Dr. Schwartz's group in 1996. And they performed transoral stimulation of the genioglossus using fine wire Teflon coated electrodes. And they were able to kind of demonstrate tongue stimulation and improve airflow, but they were also able to do it in a way that didn't result in an arousal. So that was kind of a key and important step in this process, is being able to provide the stimulation without arousing a patient from sleep. Then the group by Olivan et al. Performed, more selective stimulation, specifically of the protrusor and the retrusor muscles. And what their group was able to find was that selective intramuscular stimulation of the genioglossus significantly lowered airway collapsibility, whereas selective stimulation of the styloglossus and the hyoglossus muscles, which are thought to be retrusor muscles, increased airway collapsibility. And so they made the airway more collapsible. When the protrusors and the retrusors were activated together, the co-activation of both of these muscle groups overall resulted in a net positive airflow and a net improvement in airway collapsibility. When they took a look at this selective stimulation using nasal pharyngoscopy, so evaluation of the upper airway, they also noted another important finding in that genioglossus stimulation resulted in enlargement in multiple portions of the airway. So kind of in the top part of the pane, you see nasopharyngoscopy looking at the soft palate, and you can see that from stimulation on to stimulation on, there is an enlargement of the retropalatal space. But then also looking further down in the upper airway, looking at the retrolingual space, kind of where the tongue base is, they also noted an expansion in that region. And this was kind of a key observation that suggested that hypoglossal nerve stimulation has the potential to affect multiple levels of the pharyngeal airway, and not necessarily just the retroglossal airway. So that was a key finding. And as a result of these human feasibility studies, the first studies looking at implantable upper airway stimulation technology were performed. The first one occurring in 2001 using the Inspire One medical system. You guys might note a familiarity with the brand. So this is kind of the first pilot study that was done via Inspire Medical Systems. And this was a device that had 3 different components. It had a nerve stimulation electrode, which went around the hypoglossal nerve, an implantable pulse generator, which generates the electrical impulse, and the respiratory pressure sensor. This is a piezoelectric pressure sensor that's placed against the pleura to detect respiratory effect. And so the way that this works is by detecting the end of expiration, a signal is generated from the respiratory pressure sensor, which goes to the implantable pulse generator, which in turn sends a pulse that activates the hypoglossal nerve at the onset of inspiration. Implantation was unilateral, and stimulation was limited to inspiration to avoid neuromuscular fatigue in this study. And the implantation occurred under general anesthesia with an upper neck incision to access the hypoglossal nerve, a midline lower neck incision, as well as a right infraclavicular incision, so a 3-incision approach to implant all these components. And so for this study, 8 participants with obstructive sleep apnea underwent implantation, with sleep studies performed at 1, 3, and 6 months post-operatively. 7 of the 8 participants experienced a significant reduction in their apnea-hypopnea index. So they stratified by non-REM and REM AHI. And in non-REM it went from a mean of 52 plus or minus 20 to 23 plus or minus 12 at the 6-month period. For REM AHI, went from 48 plus or minus 31 to 17 plus or minus 17. So a pretty significant reduction in both non-REM and REM AHI. There were no adverse events reported in this pilot study, and all patients tolerated the degree of stimulation. While they mentioned in their paper that no adverse events occurred, electrode breakage and sensor malfunction did occur in 5 of the 8 participants. So I guess they didn't quite count that as an adverse event, but part of the process in kind of optimizing this therapy. Another feasibility study was then performed by the group at Eastwood et al. This was using a different device. This is the hypoglossal nerve stimulator, or HGNS, made by Apnex Medical. And these were the results of a phase 2 trial of this nerve stimulator. It included 21 participants with moderate to severe sleep apnea at 4 different sites in Australia, in patients that were unable to tolerate CPAP. Like with the preliminary pilot study that I showed, sleep studies were performed at 1, 3, and 6 months postoperative, and they were able to demonstrate a significant reduction in AHI from 43 to about 20, as well as a significant reduction in the Epworth Sleepiness Scale, or degree of sleepiness, going from 12 to 8. And the study reported 2 adverse events, one which was an infection that necessitated explantation of the device, and then one in which the stimulation lead cuff dislodged, and that also required replacement, not total removal of the device. But all patients in this study tolerated the stimulation from this device. Another device that was assessed was the Aura 6000. This was made by Emthera Medical Incorporated. This is a phase 2 clinical trial that included 14 participants with moderate to severe sleep apnea in Belgium. What's different about the Emthera compared to the HGNS and the Inspire was that this actually included a cuff electrode that is continuously activated and therefore does not require a respiratory sensor. So I don't know a whole lot about the Aura 6000, but I know that at least it has a proprietary algorithm that provides stimulation based on respiration, but isn't necessarily triggered by a respiratory sensor. And so they performed a trial in 14 participants with moderate to severe sleep apnea, measured outcomes at 1 year. They found significant reductions in AHI from 45 to 21, as well as in the ODI-4, as seen there. The only adverse events that were documented in this trial were transient tongue paresis, and that was observed in 2 patients. So there was kind of ongoing promise for this therapy, and the next larger study occurred by the group by Van de Heynig, and this looked at the Inspire 2 device, so the next generation from the Inspire 1, which was originally studied in 2001. And the Van de Heynig group carried out 2 consecutive open perspective studies looking at the Inspire 2 with a part 1 and a part 2. So part 1 was a safety and efficacy study that included 22 patients with moderate to severe sleep apnea. They included what they described as a broad selection criteria. So in general, just patients with an AHI greater than 25 and a BMI of less than 35. And they looked at kind of the sleep outcomes at 6 months. And in this kind of larger group, they actually saw no significant change in AHI from baseline within this group. So there were some responders to therapy and some non-responders. And the definition that they use for response, which is the definition that I'll use for response for kind of the remainder of the talk, is based on the Share criteria. So 50% reduction in AHI and AHI of less than 20 events per hour. And so they looked at the responders and the non-responders. There were 6 patients that responded and 20 that did not respond. And they took a look at the factors for predictors of response. And from this, they were able to see that predictors of response included an AHI of under 50, a BMI of less than 32, and the finding of no complete concentric collapse of the palate on drug-induced sleep endoscopy. And so a subset of the patients in part 1 of the study had undergone drug-induced sleep endoscopy, and a common finding of all the responders was that none of them had complete concentric collapse, whereas a common finding of the non-responders was that there was a much higher prevalence of complete concentric collapse of the palate. I'll show you guys a picture of what that looks like a little bit later in my talk. But basically, based on these responders, they then performed kind of part 2 of the trial with a subset of 8 patients that met this criteria and looked at the outcomes, and they found a statistically significant reduction in AHI among these patients. And so this was a really important study for helping to clarify and hone in on possible predictors for response to therapy. They reported infection in 2 patients, one of whom required explantation of the device. And so the findings from this study, particularly kind of the analysis of potential predictors of response, really paved the way for the STAR trial, or the Stimulation Therapy for Apnea Reduction trial. And this was an important milestone for the therapy and for the technology. This was the largest and remains the largest multi-center prospective cohort trial looking at hypoglossal nerve stimulation. Specifically, it is a cohort study, but it does not have a set control group, and we'll address that more a little bit later. The general inclusion criteria for screening for the study included patients with moderate to severe sleep apnea, CPAP intolerance, and a BMI of less than 32. And so patients were screened from 22 different academic medical centers and private practices. And the eligibility to undergo implantation was then, after kind of being screened, it had to have a baseline polysomnogram with an AHI between 20 to 50 events per hour, and of which less than 25% could be central or mixed events. They had to undergo a surgical evaluation, which was meant to demonstrate that there were no pronounced anatomic findings preventing effective use of treatment. So as an example, enlarged tonsils. If a patient had 3 or 4 plus tonsils, they were excluded from the study. And then all patients had to undergo a drug-induced sleep endoscopy, demonstrating that they did not have complete concentric collapse at the soft palate. So as part of the study, qualified participants underwent implantation with the Inspire 2 upper airway stimulation system. And then following implantation, 1 month post-implantation, they underwent a second baseline polysomnogram. This is a sleep study done before therapy was activated to kind of re-demonstrate their baseline underlying sleep apnea severity. And then after that study, they underwent immediate activation and nightly use of their device. They had follow-up visits at months 2, 3, 6, 9, and 12 months post-implantation with repeat sleep studies, Epworth Sleepiness Scales, and FOSC measurements at months 2, 6, and 12. Then at 12 months post-implantation, they recruited consecutive responders to therapy and randomized them 1-to-1 for a maintenance versus therapy maintenance versus therapy withdrawal trial. And so basically, kind of the purpose of this is that they identified responders and then randomized them 1-to-1 on a trial of therapy maintenance versus therapy withdrawal. The therapy withdrawal group had the device turned off for 7 days, whereas the therapy maintenance group had their device continued at that time. And then a sleep study was performed after this randomization to measure the effects of therapy withdrawal as compared to kind of the effects of continued use of therapy. And so kind of their overall results, they recruited 126 participants to their study, of whom 83% were men, mean age of about 55, and a mean BMI of 28. looking at their primary outcomes at 12 months, they noted a statistically significant improvement in both the AHI and the ODI. So AHI went from a mean of 32 to a mean of 15. ODI 4 went from a mean of 29 to a mean of 14. And they identified their response rate based on the Sher criteria as 66%. So basically, even after pretty careful selection of patients, only 2/3 of the patients responded, at least by the definition of the Sher criteria. Looking at their secondary outcomes, they looked at some patient-reported outcomes, the functional outcomes of sex questionnaire, and they overall noted in, functional outcomes of sleep questionnaire, and they noted an overall improvement in scores. So it went from 14 to 17, and this corresponds to an improvement in quality of life. They also looked at the Epworth Sleepiness Scale, which went from 12 to 7. So on average, patients were sleepy at baseline, and then at 12 months use had a significant reduction and were no longer sleepy. For the therapy withdrawal trial, this is the results are shown here in their graph on the right. And so, the top panel is AHI, the bottom panel is ODI4. And you can see that at their baseline polysomnography, for their baseline polysomnography, both the participants in the therapy maintenance and therapy withdrawal group had AHI of about 30 to 31. At month 12, they both had significant improvements with AHIs in 7 to 8 range before the withdrawal therapy happened. And then after the randomization, and you can see that those that continued with therapy had an AHI of about 7 days after, whereas those that were randomized for therapy withdrawal had an AHI of 26. Similar results were shown with the ODI4. In this study, there were 2 serious adverse events that were reported, and these ultimately required surgical revision with repositioning and fixation. 18% of patients reported temporary tongue weakness, but no one reported permanent tongue weakness. About 40% noted some discomfort with stimulation that improved with adjustment of settings, and about 21% reported some tongue soreness that got better with therapy use. And so, overall, what the authors concluded was that there were significant and clinically meaningful improvements in sleep apnea burden based on these trial results, and that overall it was well tolerated with a very favorable risk to benefit, very favorable risk to benefit ratio. A couple of important limitations to the study. One, as I mentioned, the response rate. Even with really careful patient selection, the response rate was still only 66%. And so that's kind of important caveat to consider when interpreting the results of this study, as well as kind of understanding kind of what this means for the therapy moving on to the future. It's also important to note that, positional data for sleep studies, as well as, REM versus non-REM AHI were not reported. And, something that I gained an appreciation for during my fellowship is that, a sleep study is not a sleep study is not a sleep study. And, without having that positional data and seeing, what degree of the studies were supine in the baseline studies versus in the post-therapy studies, it can make it somewhat challenging to compare the results of the study and kind of understand really the true impact of the therapy alone. That's an important compounder that was not addressed in the study. And importantly, the study was published in the New England Journal of Medicine, and it did have a component of it that had a randomized withdrawal of therapy, but the study itself was not a randomized control trial and actually did not have a control group. It was a large cohort study that followed patients. Nonetheless, based on the results of the study in 2014, the Inspire 2 upper airway stimulation system was granted FDA approval. And it is currently the only upper airway stimulation system that has FDA approval on the market right now. The indications for it are it's indicated in adult patients age 18 over, patients with moderate to severe sleep apnea. It was originally indicated for those with an AHI of 20 to 50 based on the STAR trial, but in 2017, that was expanded to an AHI of 15 to 65. It's indicated for patients with a BMI of less than 32. There are some insurances that will do it for a BMI of under 35, but the primary indications for BMI of under 32. As part of placement, there's a requirement that all patients that undergo consideration for Inspire placement have to undergo a drug-induced sleep endoscopy to demonstrate no complete concentric collapse at the soft palate. And patients also have to have a demonstrated intolerance to CPAP, and intolerance is defined by inability to use PAP in a compliant manner, so greater than 5 nights per week, greater than 4 hours per night, or unwillingness to use PAP. So if a patient returns their PAP system after attempting to use it. Some important contraindications, having, basically sleep study findings demonstrating a total AHI with greater than 25% central or mixed apneas. That's concerning for a process other than obstructive sleep apnea contributing to the patient's overall burden. And so that's a contraindication for therapy. Additionally, anatomic findings that compromise performance, such as enlarged tonsils or complete concentric collapse on drug-induced sleep endoscopy. Any condition with compromised neurologic control of the upper airway, inability to operate the sleep remote. There's a remote that comes with therapy, and patients need to be able to use this to titrate to therapy, turn it on and off. So that's a contraindication. BMI greater than 35, and conditions requiring need for ongoing MRI. This is an area that is kind of in the process of changing. And so some of the newer versions of the Inspire that are coming out are going to have approval for MRI. And my understanding is that they were in the process of getting approval for some of their newer devices, but I don't know if that's completely come through just yet. So now a little bit just about clinical implementation for Inspire. As far as kind of how the process goes, there's a kind of certain things that are important for the preoperative evaluation. There's the initial consultation with a sleep otolaryngologist, followed by a drug-induced sleep endoscopy to evaluate the upper airway under the sedated state to assess for complete concentric collapse, and the preoperative visit. Here's a slide just kind of briefly demonstrating what that might look like. So, here on the left, we see the nasal endoscope that's through the nose into the nasopharynx with an evaluation of the soft palate. And these are some possible, findings that you might see. And so kind of here on the left, we see what we call anterior posterior collapse of the palate. It's when kind of the palate collapses in an anterior posterior manner against the posterior pharyngeal wall. And then here we have what we call complete concentric collapse. You can see kind of more the palate looks like a sphincter there with pretty significant lateral wall collapse from the finding. And so basically what the drug-induced sleep endoscopy is screening for is what we see here on the right, this complete concentric collapse. So some brief surgical details. I won't get into the weeds with this too much, but the original description of the procedure had 3 incisions, one in the neck for the placement of the cuffed electrode for the hypoglossal nerve, kind of one in the chest for the implantable pulse generator, and then one for the respiratory sensor. Now it's being done via a 2-incision approach, and so doing one in the neck and one in the chest, which with the chest incision allowing access for both the placement of the implantable pulse generator and the respiratory sensing lead, as demonstrated here. So as far as postoperative management is concerned, we typically have patients come back in about a week for a wound check to make sure that wounds are healing appropriately. And then at the 1 month visit after surgery, they would undergo activation, after which they would begin to self-titrate their own therapy. This is just a sample of an activation visit, just showing the tongue exam here. Go ahead and play this for you guys. So you can see when the stimulation is about to come, and there you see stimulation of the tongue with protrusion of the tongue on an activation visit. And then this is what it looks like on awake supine endoscopy. So this is with a nasal pharyngoscope in the upper airway, looking at the palate, and it's done supine. The patient's awake, of course, and there with therapy on, you can see protrusion of the tongue with expansion of the airway. You can see that it happens both at the retropalatal and the retrolingual spaces. So after the activation visit, patients will start to titrate their own therapy, and they'll basically start low and gradually increase their therapy as they're able to tolerate it. Once they've gotten to a stable point where they've up titrated and they're at a point where it feels comfortable, they'll go an in-lab titration study to kind of assess for the optimal voltage level for hypoglossal nerve stimulation therapy. They'll review that about 3 to 4 months after their initial surgery. At that point, if there are any issues, if there's any concerns with responsive therapy on the titration study, we'll kind of review that, optimize therapy and parameters, also optimize factors that are challenging use, such as if for some reason the stimulation is causing the patient to have difficulty tolerating the therapy. At 6 months, patients would undergo a home sleep apnea test at their titrated settings. And, in contrast to the in-lab titration study, which is kind of an effectiveness study, this is more of an, the in-lab titration study, which was an efficacy study. The home sleep apnea test was more of an effectiveness study, seeing how patients did kind of in a real world environment at their titrated setting, and seeing how they tolerated therapy. 7 to 9 months, we'd review the sleep apnea, troubleshoot issues via changing parameters. And then at 12 months, patients would resume kind of usual follow-up with their sleep medicine physician and undergo annual assessments, sort of like with annual CPAP compliance and visits. This is a slide just showing a montage of a in-lab titration study for hypoglossal nerve stimulation. You can kind of see several of the different channels, starting from the EEG leads, the tongue, some mental EMG leads, the nasal pressure airflow, followed by chest and abdominal excursion and oxygen saturation. This is obviously a very pretty demonstration of this phenomenon, but you can see that kind of in the left part of the montage, so the first couple of minutes, you can see kind of repeated obstructive events with associated desaturations. You can see the green shaded box in the right portion of the montage demonstrating activation of therapy, as you can see by the repeated EMG stimulations, and in the kind of green box demonstration of kind of improved airflow, decreased airflow limitations and improvement in oxygen saturation. I wish that all of the titration studies looked as pretty as this one. This is obviously one that was published, but the reality is that they don't all look quite like this with activation of therapy. A little bit of information on long-term outcomes. So the STAR trial, which was kind of the original results in 2014, has published kind of repeated findings from their cohort at 12 months, 18 months, 3 years, and 5 years. And a couple of years ago, they published their 5-year outcomes, and some brief results from that here. Of the 126 that underwent implantation, over the 5-year period, a total of 21 were lost to follow-up, 5 died of unrelated causes, and 3 had their device explanted, 2 because of non-response, 1 because of infection. And so for kind of their 5-year outcomes, 97 patients were included, of whom 71 underwent voluntary repeat sleep studies at that time. Looking at the 5-year outcomes, kind of what was noted here is among the patients that participated in the 5-year study, there was kind of this kind of sustained benefit in sleep apnea burden as measured both by AHI and ODI-4. You can see significant improvements, and you can see here a graph showing AHI on the y-axis and time on the x-axis. You can see that patients improved in that improvement appeared durable during the 5 years of that study. The response rate that they cited overall from this was 75%, but when they did a lapse observation carried forward analysis to account for patients that did not follow up, their adjusted response rate was 63%, and that's based on the Sher criteria. Looking at patient-reported outcomes, for the FOSC, you see this improvement over the 5-year period, which appears sustained. One of the things that really bugs me about these graphs is that they're not centered on 0. So, it goes from 14 to 18. So it looks like this really big improvement. It's a modest improvement in the FOSC, but it's modest. And in the Epworth, you see it went from 12 at baseline to 7 at the 5-year, and you can see that benefit was sustained over the 5-year period. Over the study period, there were 9 adverse events in 8 participants. 1 participant had 2, unfortunately, and these ultimately required revision, surgical revision of the implanted pulse generator or the cuff electrode. As far as non-serious adverse events, the most common were discomfort secondary to electrical stimulation, which tended to be prominent within the first year and decreased over time, as well as a tongue abrasion, which followed a similar pattern. So we just talked about Inspire. Inspire is the only FDA-approved device on the market, but it's kind of important to know what else is out there and what else is in the pipeline. I mentioned a couple of these with the original feasibility trials. There's the Aura 6000, which is demonstrated here, the HGNS by Apnix Medical, and unfortunately for the Apnix. The Apnix device was promising in the phase 2 trial, but then failed at phase 3, and ultimately that company actually no longer exists. It went bankrupt, and so that's no longer available. But that's one that was studied pretty extensively. And then the last that I haven't mentioned yet, but is kind of under current active investigation, is the Genio by Nyxoah. So the Genio is different in a few ways. One is that it's a device that allows for bilateral hypoglossal nerve stimulation using bilateral padded electrodes. It doesn't have any implanted leads or batteries, and it doesn't have a respiratory sensor. And so as a result, this can be implanted using only 1 incision, which is kind of in the submental region. And because it doesn't have an implanted battery, it doesn't need to undergo battery changes. So, with the Inspire, the battery needs to be changed about every 10 to 11 years. We haven't gotten to that point yet because, we're just coming up on some of the 10-year folks right now. But those are some of the advantages that the Genio affords. And so a couple of the components listed here. One is the implantable stimulator with padded electrodes bilaterally. You can see here on the right side what that looks like. Number 2 is a disposable patch that patients wear at night. And number 3 is the activation chip, which is charged externally. So that's the power source for this device. Only number 1, which is the implantable stimulator, is implanted as part of the surgery. And so after implantations, patients will put a patch on. They'll put the the kind of the external power source on, will sleep with that, and then in the morning take it all off. So they still have to wear something while they sleep, but the power source is external as opposed to with the Inspire. So that's currently under active clinical investigation. As part of my fellowship, I had the opportunity to partake in the care of 2 of these patients, and so it was pretty interesting to see this done, to be able to perform this surgery, and we'll be excited to see what the outcomes show. Some important future directions with this therapy. So, we talked about different options, but the development of novel upper airway stimulation devices is kind of critical. Right now, Inspire is the only FDA approved, and it's the only one on the market. I think that as a surgeon, it would benefit patients and would benefit the therapy for there to be a healthy competition in this realm, so that patients can have more than one option. And in addition to the Genio, which I showed, there's also some promise being shown with some ansa-cervicalis stimulators, and will be exciting to see what the results of those show in the future. An expansion of clinical uses, and so one area that's being very heavily investigated is use in patients with Down syndrome, particularly children with Down syndrome that have pediatric sleep apnea. There's some very promising results there, and it holds a lot of promise as a potential sleep apnea treatment for these children. And then ultimately an improvement in patient response rate. And so this is kind of the real crux and Achilles heel of the therapy, is that we've identified several kind of predictors for response to therapy, and even in these very carefully selected patients, with BMI criteria, AHI criteria, the drug-induced sleep endoscopy findings. These studies, the response rate was kind of between 65 to 70%, and it's gradually gotten better, but I still think that we don't quite have a handle on some of these predictors to response. I think that there's some compelling evidence that kind of further incorporation of physiologic assessments could play a large role in improving patient response to treatment. And I know that a lot of those efforts are ongoing. So some take-home points before I answer a couple of questions. The genioglossus muscle plays a key role in upper airway patency, and that forms the foundation for this therapy. Upper airway stimulation shows tremendous promise as a CPAP alternative treatment for sleep apnea, with demonstrated improvements in both physiologic parameters and day-to-day symptom burdens of obstructive sleep apnea. But very evidently, further work is needed to really optimize the therapy in order to improve response and really understand why some patients are adequate responders to therapy and why some are less responders, even after careful selection. Thank you for giving me the opportunity to present today. I really appreciate that, and I'd be happy to answer any questions.
Hi, Sebastian. Thank you so much for giving that outstanding talk. You have a large audience relative to our usual speakers. There are a number of questions that are being posed on the chat, and I'd like to start with those before people start asking additional questions.
Sure. Yeah, I guess I'm going to start from kind of the top, and I'll work down. So first question I had was putting up a few questions. What's the present adherence of those implanted to the strict implant criteria from the STAR trial? And then is treatment using a Genio Nexilla device only through clinical trials in the US? So the first question is, the adherence. From what I've seen, I've seen adherence correspond roughly to response rate, so about kind of 70%. In terms of kind of tolerability, the Inspire company has gone to pretty big measures to optimize the postoperative care to really improve adherence and tolerance. It's that's kind of from what I've seen published. There's the there's kind of the physiologic response of, is this treating the sleep apnea? And then there's the adherence, which are patients tolerating treatment. I've seen that at roughly 70%, but I don't know how well documented that is in the STAR trial or others. I'd have to take a look back. The second question is treatment using Genio only through clinical trials in the US? And yes, it's currently available only through clinical trials right now. It's not FDA approved, but I know that the clinical trials are well underway for that. What were the next question I had was, what were the repositioning side effects on the STAR trial at the nerve cuff? And is this just why was repositioning necessary, or what were the consequences of performing this, just to clarify?
Yeah, so, hey, Sebastian, I guess I was just trying to figure out what exactly that meant when it said needed repositioning. I assume it was at the cuff for the nerve where it had moved or migrated and needed.
Yeah, it occurred at two different places. One was at the nerve to repositioning the cuff, and the other is fixating the implantable pulse generator. Sometimes I can hang too low in the pocket and create tightness of the connection that can cause pretty significant discomfort and requires some repositioning. Next comment, the positional criteria didn't make it onto the FDA indications per STAR trial, excluded from enrollment if non-supine was less than AHI of 10. You know, I mentioned the lack of positional data as a limitation of the STAR trial. You know, I don't know the details specifically, but I think that it's really hard to compare pre and post-operative studies if you don't have the positional data, or if you don't have kind of the REM versus non-REM breakdown, just because it can make a pretty big difference in how you interpret the findings. Next question I saw was, any contraindications for cardiovascular disease or pulmonary comorbidities if no severe hypoxemia, hypoventilation? Is similar risk as a pacemaker implantation? You know, as far as that's concerned, I would have to look at the specific contraindications, but I don't believe that cardiovascular or pulmonary comorbidities are strictly contraindicated. I know that central sleep apnea is contraindicated. And so the key here is for those patients really ensuring that their sleep apnea is more obstructive than central. And that's something I know that Dr. Dadia went to pretty great lengths to ensure prior to performing the implantations. Can titration be done entirely by trial and error based on tolerance in the clinic, followed ultimately by HSAT to obviate the in-lab polysomnogram? So, you know, I think the answer is probably yes. You know, patients will self-titrate and kind of see how they do every night with therapy, with increasing levels of stimulation, to the point where they kind of, you can almost think of it as kind of keeping your finger in a pot of boiling water and then taking it out when it gets too hot. So they can kind of keep increasing until they experience discomfort and get to a level where they can kind of tolerate that. And then at that level, see if the therapy is having an effect. You know, the in-lab PSG is nice because it really gives a sense of airflow limitation. Also gives you know, gives us kind of that detail and that feedback with the sleep tech of how the patient's doing on certain therapies, whether you know, they tried a certain stimulation level but then woke up from it and complained of it being painful, so it was lowered. So it gives you that kind of extra level of detail that you might not get in a home sleep apnea test. In the future, it may get to a point where it could be kind of self-titrated and done with an HSAT, but I think that the in-lab titration provides really important help in this process. And then Dr. Kapoor asked, what happens to the non-responders? So, you know, there was, they don't specifically mention in the STAR trial. What I will say is, you know, in kind of the clinical practice that I saw in fellowship, you know, when there was non-response, we'd really try hard to figure out why there was a non-response. Was the therapy turning on and just not doing anything in terms of relieving airflow obstruction? Is it because of arousal? You know, what we'd find kind of a fair amount is that the therapy would work really well in non-supine sleep, and then supine sleep would get there and it would just be terrible. Or, you know, supine REM sleep would come and it, you know, it'd be really, you know, it'd be really bad from that standpoint. You know, in the non-responders, we would kind of assess for these features, you know, work in clinic to adjust their settings. So, you know, I didn't get into this in too much detail, but you can adjust kind of the frequency and amplitude of the stimulation to try to stimulate further. You can change the electrode configuration. These are kind of some really nuanced details to help improve the stimulation and counteract that with patient tolerance. If that wasn't successful, then we consider doing a repeat drug-induced sleep endoscopy with the therapy on to see kind of what's happening in the airway with the therapy on, and potentially offering adjunct treatments in addition to the hypoglossal nerve stimulation. So, you know, there's some patients that achieve successful therapy with both Inspire and some upper airway surgery. So that's kind of how we would manage it. And I think that process is still an iterative process in terms of really trying to figure out how best to manage those patients.
So can I ask you a good question, Sebastian?
Yes, of course.
Stina here. Are you planning to establish this as a practice here at UW, or do you already have it? And how can we potentially collaborate with you to get it accomplished?
Thank you for that question. So, you know, the part of, you know, my current position is a temporary position. So I'm not going to be here long term. Unfortunately, that's just for personal circumstances. I'm working with some of my partners in Northwest Hospital, as well as with Dr. Weaver and Dr. Kapoor, about potentially starting to implement this. I know that Dr. Shah has taken, at Northwest Hospital, has taken a lot of the lead with trying to get approval for the device, and I know that it's been approved, and now we're in the process of identifying some patients. As far as kind of establishing this, I am more than happy to kind of lend my experience and expertise to help get this off the ground. Unfortunately, because I'm not planning on staying long term, it's not something that I'll be overseeing, and so I'm very mindful about who owns what and who does what. And my goal would be to help establish things so that it could be continued by all the stakeholders at hand here at UW.
But it would be through Northwest then, you think? If it does get established, probably the otolaryngology service at Northwest will be providing the service. Is that where you see the movement most?
Yeah, I think it would predominantly be through there. Perfect. I know we're a little bit over 1 o'clock. I see one last question by Dr. Consens. Sorry if hope I'm pronouncing that correctly. Can you comment on other practical poor indicators in response, such as insomnia, dental prosthetics, et cetera? So, I think insomnia is certainly one potential predictor of poor response, just because that is something that can affect arousability and kind of response to stimulation from the therapy. And so that's something that we certainly look to screen for very closely. And the difference between kind of sleep onset insomnia and sleep maintenance insomnia, the sleep onset insomnia tends to be more challenging than the sleep maintenance insomnia. There's certain kind of tricks to helping with that. Part of it is setting the therapy parameters. Part of it is adjusting when the therapy comes on. So if the patient takes, an hour to fall asleep, the device can be programmed to come on in an hour and a half, for example. And then, if that kind of remains an ongoing issue, kind of working with our colleagues in sleep medicine for cognitive behavioral therapy for insomnia to help address that component of symptoms. Dental prosthetics, not so much a poor indicator. One that is having promise as a potential poor indicator that is being actively looked at by Dr. Dadia and the group at Penn is actually airway collapsibility. And so we look at the drug-induced sleep endoscopy, and what we report in a standardized measure is the sites of collapse and the degree of visual collapse that we see. But there's this extra dimension of collapsibility, how much pressure is needed to hold open the airway. So, the critical opening pressure, the P crit, and then this measure that they're using, which they've termed the pharyngeal opening pressure, or the FOP, which is how much pressure is needed to relieve flow limitation and to open the airway. And there's some compelling evidence that patients with higher degrees of collapsibility, so those that need large amounts of pressure to open the airway, tend to be poor responders of therapy, while those that have kind of a low collapsibility, so they don't need as much pressure to stent their airway open, tend to respond better to therapy. There's some preliminary data that Dr. Dadia has published on that leads to this, and I know that that's an area of active investigation by his group.
Great, thank you. The dental prosthetic is because I have a patient that had like some kind of dental piece that was a bridge or something. It wasn't an implant, and because of the movement of the tongue through the night, it got significant injuries of the tongue, and wow. He could not tolerate it. So
I see, because of tongue abrasions.
Yeah.
I think some people use mouth guards to help with the tongue abrasion aspect, though. I know that.
Yeah, but no, great review. Thank you so much.
Yeah.
Thanks, Sebastian.
Yeah. Thank you for giving me the opportunity. I really appreciate it.
Take care.
Take care.